In this presentation, we'll be reviewing the positioning criteria for the large intestine as it relates to the performance of barium enemas. Barium enema series consists of these typical views. Routine views include PA or AP, the sigmoid view, RAO and LAO, LPO and RPO, the lateral rectum, right and left lateral decubitus for double contrast, cross-table lateral rectum for double contrast, and a PA post-evac. Special views may include the AP axial or AP axial oblique for the sigmoid, the PA axial or PA axial oblique for the sigmoid, and not listed here may be upright positions. Positioning for the upright positions are the same as for recumbent, except the IR is placed slightly lower to compensate for the drop of anatomy due to gravity. For the PA large intestine, position the patient prone. The central ray enters at the level of the iliac crest at the MSP. Use 14 by 17 collimation and expose on suspended expiration. The entire colon should be visualized. Here we can see the difference between double contrast on the left, single contrast in the middle, and a post-evacuation image on the right. You notice variation in shape of the large intestine between patients radiographically as well. Keep this in mind during the fluoroscopic routine to help you adjust positioning appropriately for these overhead images to include the entire colon. AP large intestine. The positioning criteria is the same as for the PA with two distinct differences. The patient is supine, of course, but also place the table in slight Trendelenburg position to aid in contrast retention. When viewing your radiographs for quality control, make sure to check for rotation with bony anatomy such as the wings of the pelvis and the vertebral column, and ensure that the entire colon is visualized. From the top, the splenic flexure is most superior. Some patients with hyperstenic body habitus may also need a crosswise IR placement. If that's the case, then one upper abdomen and one lower abdomen exposure may be required for the AP, PA, and or the obliques. The PA axial large intestine. This view can be performed PA or AP. Here we'll look at the PA method. Angle the CR 30 to 40 degrees caudad and center midline at the level of the ASIS. Use a 10 by 12 collimated field and make sure to include the rectosigmoid colon. This view provides less superimposition of the sigmoid and rectum over one another than the straight AP or PA views with no angle. This view should include the entire sigmoid colon, all the way down to the rectum, with the balloon visible inferiorly on the radiograph. Notice how the extreme angle elongates the bony structures of the pelvis. For the AP axial large intestine, you'll need to apply the same 30 to 40 degree angulation to the X-ray tube, only cephalic this time with the patient supine. Center midline approximately 2 inches below the ASIS, restricting the beam to a 10 by 12 field. This provides a similar view of the rectosigmoid colon free of superimposition, and the superior portions of the colon, the ascending, descending, and transverse portions, are not required to include on this view. Though the image on the left is one of the textbook examples, collimation should have been applied to a greater degree here. The image on the right is more appropriate to visualize the necessary anatomy. Notice how much of the pelvis is visible on the right compared to the entire pelvis and large intestine, minus the superior portion of the splenic flexure on the left. For the oblique large intestine, this can be done anteriorly or posteriorly. Practice the entire BE routine as a series and find out what works best for you, considering what may be easiest for the patient each time. I personally prefer the LPO view, but the RAO view will demonstrate the same anatomy. Consult your departmental routine for double contrast studies, as contrast displacement will be different between LPO and RAO views. The patient should be rotated between 35 and 40 degrees, regardless of whether you perform LPO or RAO, with the central ray directed 1 to 2 inches lateral to midline towards the elevated side at the level of the iliac crest. Collimate to a 14 by 17 field to include the entire colon. This view should demonstrate the right colic or hepatic flexure in profile, as well as the ascending colon free of superimposition and the sigmoid colon. Let's take a look at these single contrast images. There's a significant difference between the position of the transverse colon between these images. Remember, the transverse colon curves anteriorly from the hepatic flexure to midline, then starts curving posteriorly again as it leads towards the splenic flexure. We'll give you a great study tool to remember this structure in lab this week, but you'll need to remember this in order to determine which oblique to perform to demonstrate each portion of the colon as well as the flexures. Here we see some double contrast views. Notice how the contrast is disrupted differently between the RA view on the left and the LPO view on the right. Another detail to note is how far away from midline the colon extends in the oblique position. The textbook CR states 1 to 2 inches lateral from midline. However, with hypersthenic patients with large abdomens, the CR may need to be adjusted more laterally. You can see in the image on the left that the descending colon and splenic flexure are closer to the edge of the IR. Also note that there's similarity on the patient's right, regardless of the size, showing that the ascending colon typically doesn't move far left to right from the bony landmarks of the ASIS. You should always make sure the exposure field on the patient's right side includes the ASIS to ensure you don't clip anatomy. Looking at the opposite oblique, we can utilize the same criteria for LAO and RPO views. Rotating the patient 35 to 45 degrees and centering 1 to 2 inches lateral to midline towards the upside. This view will best demonstrate the left colic or splenic flexure and the descending colon free of superimposition. One common positioning error performed with these obliques that also applies to the lumbar spine is unequal rotation between shoulders and hips. I find that using a 45-degree wedge sponge supporting both shoulders and hips is a great way to make sure you're not over or under rotated when comparing these two sections. Again, we have the single contrast views of the LAO on the left and the RPO on the right. While we're primarily looking for the splenic flexure to be in profile here, you can also note the position of the pelvis, which would be pretty close to the oblique lumbar spine. You can also see the Scotty dogs and apply knowledge of over/under rotation for the spinal anatomy here. After a few exams, you'll begin to notice that even if the Scotty dogs are visible, the flexures will vary in demonstration with body habitus, sometimes requiring more or less rotation compared to the bony anatomy. And again, we see the LOA and RPO comparisons with double contrast. These views should be performed based on where the radiologist would like to see the contrast distributed, while the single contrast views are selected more for patient comfort and/or technologist preference, since the contrasts look the same. For the lateral rectum, patient needs to be placed in the true lateral position with knees bent. Hips and shoulders should be perpendicular to the table with the pelvis lateral. The CR enters the mid-coronal plane at the level of the ASIS. This view can be performed for both single and double contrast exams. However, sometimes the double contrast exam calls for a cross-table lateral, which I'll cover next. Regardless of the patient position, a 10 by 12 field of view can be used. I am a huge supporter of collimation for this view since the field of view lies so close to the genitals. Keep in mind the rectum does not extend superior of L5, so you can place the top of your light field around the iliac crest. It also lies just anterior to the sacrum, so simply include the sacrum in your collimated field. Inferiorly, if you can collimate to the anus where the visible enema tip is protruding, you will never clip the anatomy. The cross-table lateral is not included in the textbook, but it is popular for double contrast routines and would typically be the last view to perform once you've identified all the other images do not require repeats or additional views. Essentially, the positioning criteria is the same with the patient prone. However, some routines require removal of the enema tip immediately before exposing the image. Make sure you have all of your equipment set up with a receptacle nearby for when you remove the enema tip, along with some towels for the patient. Set up your technical factors at the control panel, align your X-ray tube and image receptor, and instruct the patient that your going to deflate the balloon and remove the tip. And they need to attempt to hold the contrast in as much as possible for a few seconds while you obtain the exposure. When ready, deflate the balloon and toss the bag and tip into the receptacle, then make your exposure. As soon as you can, return to the patient and provide them with a towel to take care of any leakage, then escort them to the restroom to evacuate. You can use this time to clean your X-ray table if needed and prepare for your post-evac image if required. The other views you may be required to perform include lateral decubitus images. These views are only performed during double contrast studies, and timing is key. If you're going to perform them at the end of your overhead routine, the air can sometimes dissipate, and you may need to ask the radiologist if additional air needs to be added. For this reason, I like to perform them at the beginning of the overhead routine, but again, do what works for you. There's no perfect order for every situation, but there are many things to consider. For the right lateral decubitus, the patient is in the right lateral position with a radiolucent support if needed under the abdomen. Center to the MSP at the level of the iliac crest with a horizontal beam. Place your marker on the upside. This view displays the medial aspect of the ascending colon and the lateral aspect of the descending colon. The idea is that the best demonstrated portions are those that have been coated by contrast, but filled with air. Remember, contrast is going to follow gravity, so the upside of each portion of the colon will be demonstrated best. For the left lateral decubitus, the positioning criteria is the same, although the CR may be entering posteriorly. Don't forget to change your marker on the image receptor and mark the upside. Center to the MSP at the level of the iliac crest and include the entire colon. This view demonstrates the lateral aspect of the ascending colon and the medial aspect of the descending colon. The textbook shows that decubitus views hung as shot. However, I've seen some radiologists who prefer this versus some who prefer images to be hung in the anatomical position. Make sure you know which way is preferred for the radiologist you work with. Occasionally, a double contrast routine may call for upright views to demonstrate the transverse colon. While these are more rare to perform, keep in mind when centering whether or not you are required to include the entire colon or just the transverse for your routine. Also remember that the colon may migrate inferiorly with gravity in the upright position. After the overhead views have been completed and you have verified that no additional views are required by the radiologist, a PA or AP post-evac film may be requested. This should be positioned the same way the KUB is positioned, but with high KV as used with contrast studies. Center the MSP at the level of the iliac crest and expose on suspended expiration. Include the entire large intestine. The patient should be encouraged to evacuate as much as possible prior to this image, and they may take a little bit of time in the restroom before coming back out. As previously stated, you can be cleaning your X-ray table, the exam room, documenting pertinent details about the procedure, or annotating your previous views while the patient is in the restroom. But don't forget to check on them frequently, keeping in mind that this exam is physically exerting, and they have been NPO on top of it. There's a risk for dizziness and fatigue at the end of this exam. I also find that having a clean gown, 2 or 3 towels, and 2 or 3 washcloths already in the restroom for the patient is really helpful. This is typically part of my room setup before the procedure, but they should be encouraged to clean all of the barium off their skin and change gowns if any barium has leaked onto their first one. Excess barium that was spilled can cause unwanted artifacts on your images, and the patient really doesn't want to continue on with soiled linen at this point. As a side note, when the post-evac images are complete, the patient should be informed that they should be drinking plenty of water to flush out any remaining barium, and to expect their stool to be white or chalky in appearance. If they experience constipation that an over-the-counter laxative doesn't resolve, they need to contact their physician as well.